This new medical field of cardio-oncology has grown out of the success of modern oncology and hematology treatments. So now as more and more people are living either with their disease, controlled by medication, or cured, they're living to get potential complications. We have a success of people surviving cardiac disease such as myocardial infarction in their 40s and 50s to live and get new malignancies in their later life. So more and more the patients are older and they come with pre-existing cardiac problems. There's also the younger patient where we want to protect them from their long-term effects. We've known about this for many years with anthracycline chemotherapy and with radiation to the heart. But where this whole field has exploded is all the modern designer drugs, the molecular targeted therapies and now immunotherapies, which are having a dramatic impact on previously lethal malignancies, but where there is a cardiac concern and now these are growing. It's really interesting because it's teaching us about the biology of the heart and the blood vessels and vascular system, that there's this yin-yang. That's to say that the pathways driving the cancer that are being inhibited by the new treatments are actually performing protective pathways in the heart. So lots of these molecules, which are seen as the bad guys in oncology, are the good guys in cardiology, and we're looking at trying to stimulate them to increase survival pathways in the heart in people with heart disease. So it's not surprising a designer drug that blocks them effectively can cause cardiac problems. And we're seeing this across a broad range of malignancies. So if we focus on the hematological malignancies, of course there are the lymphoma patients who are getting high doses of anthracyclines. As a cardiologist, a high dose is 200 milligrams per meter squared or more. So traditionally considered safer doses actually in older patients, people with diabetes, smoking, these are higher doses. And then there's the new leukemia drugs, particularly for chronic myeloid leukemia. Second and third line drugs, once people have broken through imatinib, tend to have a range of cardiotoxic issues, including arrhythmia, thrombosis, pulmonary hypertension, and heart failure. We're seeing more and more in myeloma patients. A lot of myeloma patients are old. They have pre-existing cardiovascular disease and renal disease leading to hypertension. And the proteasomal inhibitors, particularly the more irreversible inhibitors, are causing a high degree of heart failure and also myocardial infarction. Ibrutinib, having a big impact in CLL, has got some arrhythmia risks, and rarely, but I've seen it, some heart failure as well. As more and more hematology patients are living with their diseases either cured or controlled, we need to be monitoring them. So our strategy is to prevent this. And the way we prevent it is by organising a baseline risk assessment of their cardiovascular health before they start, flagging up high-risk patients who may need to then go and see a cardiologist, or now in these special centres, cardio-oncology, where you have cardiologists who understand the mechanisms of the problems and can engage with the cardiologists, with the oncologists, because it's a team approach. And then from this, we can monitor patients more closely, or maybe start up front with some protection so that they can have their treatment safely.